this session. We are recording the session now, just so that full disclosure, everybody knows. Okay, so I would like to first acknowledge that the Thunder Bay Drug Strategy recognizes First Nations, Métis, and Inuit people as traditional stewards of the land we now call Canada. Thunder Bay, where we are physically hosting this webinar and meeting, is located on the traditional lands of the Ojibwe people of Fort William First Nation in the Robinson Superior Treaty area of 1865. Northwestern Ontario is also home to 4 other treaty territories: Treaty 3, Treaty 9, including the adhesion to Treaty 9, and Treaty 5. And we acknowledge and thank the diverse Indigenous peoples whose footsteps have marked these territories for centuries, where we gather together today. So I have gone through some housekeeping. Just make sure I've got all of those. And next, I would just like to thank everybody who's come here in person, who is maybe watching on Facebook Live, and for all those who have registered and are watching through the webinar feature, for your interest and your time to come out and hear the results of our region-wide engagement about the feasibility of developing a Northern Centre of Excellence for Addiction and Mental Health. So I actually have to click on this. Okay. So to my right, I have Dr. Christopher Mushquash, and he will be presenting. He is the director for the Center for Rural and Northern Health Research at Lakehead University, and Dr. Mary Ellen Hill, who is the senior researcher for CRaNHR. So you might hear me say CRaNHR, which is short for Center for Rural and Northern Health Research. So we thought we would start by actually sharing where this project may have started. It wasn't just that we decided that we should pursue this regional engagement. Back in 2009, Thunder Bay Regional Health Sciences Center developed a working group to address opioid addiction in the region. In 2009, the drug strategy through the health unit received funding to consult with the community and develop a community-informed and community-implemented plan to address substance-related harm. In 2011, that plan was endorsed by both the Board of Health and City Council as the official community plan. In 2012, an issues report from the drug strategy to the health unit was prepared, acknowledging that Northwestern Ontario faces a challenge in reducing substance-related harms due to limited capacity to meet demand for services, nearly non-existent capacity to conduct locally relevant research, and for long-term solutions to be successful, Northwestern Ontario must be supported to develop local, culturally relevant, and sustainable wellness approaches. The project itself officially began in 2013 when Dr. David Williams, then the Medical Officer of Health for the Thunder Bay District Health Unit, who is currently the Chief Medical Officer of Health in Ontario, began discussions with stakeholders about the opioid crisis and brought an issues report to the Board of Health. There was a recognition that opioid use and related harms was a public health crisis, and especially serious in Northwestern Ontario. There was also the recognition that the drug strategy had already been formed with multiple community partners coming together to implement a community-based and community-informed plan, and an acknowledgement that Northern Ontario First Nations had repeatedly expressed concerns with respect to the serious harms that opiates were having on their communities. That the mental health strategy of Canada, Changing Directions, Changing Lives, recognized that Northern communities confront some of the most challenging and complex mental health and social issues, and that the community itself is its own best resource, and that the Ministry of Health and Long-Term Care's expert panel on narcotic addiction produced recommendations and identified Ontario's North as a specific area of concern, and that a strong foundation of system supports and commitment to evidence-based interventions, monitoring, evaluation, research, and the promotion of sharing knowledge through lessons learned and best practices was needed. In July of 2013, the Thunder Bay Drug Strategy and the Thunder Bay District Health Unit officially formed a small group and began discussions around preparing a proposal for the Ministry of Health and Long-Term Care to conduct a region-wide engagement process. The goal was to explore provider and consumer views about addiction issues and needs to better support communities in developing local, effective, and sustainable approaches to wellness. It recognized that in order to do this region-wide engagement, that the Northwest LHIN has unique challenges, that area. Geographically, it's vast, but has a very small population, especially difficult to develop services that meet the needs of people living in small towns, rural areas, and remote communities. And there is a significant Indigenous population compared to the rest of the province. The region will also require diverse, culturally safe, and contextually relevant treatment options for and by Indigenous peoples. And 1 in 3 residents of Northwestern Ontario are 25 or younger. So a priority to develop services that address the needs of teens and young adults must be ensured that it was envisioned. The plan itself, we would need to develop wellness approaches that build capacity in northern, rural, and First Nation communities, and it would need to respond to the needs of a diverse population with an emphasis on culturally safe and age-appropriate care. This is where the Thunder Bay Drug Strategy and Thunder Bay District Health Unit invited Lakehead University through the Centre for Rural and Northern Health Research to partner to develop a proposal to the Ministry of Health and Long-Term Care. Through collaboration between the Drug Strategy, the Health Unit, and CRaNHR, and a stakeholder advisory group, a proposal was submitted to the Ministry of Health in February of 2014. By 2015, we were acknowledged that we were unsuccessful in our original proposal to the Ministry of Health and Long-Term Care. Shortly thereafter, I would say about 2016, we were given word that our proposal had been dusted off, and we were engaged to update that engagement and the proposal and resubmit to the Ministry of Health and Long-Term Care, and funding arrived in January of 2017 through a knowledge translation project grant to support the engagement across Northwestern Ontario. I'd just like to acknowledge the next steps with forming the advisory committee. We had St. Joseph's Care Group, Daliko Anishinabek Family Care, the City of Thunder Bay Counseling, Thunder Bay District Health Unit, Northwestern Health Unit, Sioux Lookout Mino Yawin Health Center, and Lakehead University, who formed the advisory and guided the project as we continued down this path. Our main goal was to engage with a wide variety of key stakeholders and hear from people with lived experience. We wanted to hear their views around the potential for improving substance use and mental health services, and focus in on their views around the development of potential for improving services through developing a Northern Center of Excellence for Addiction and Mental Health. The key questions that we wanted answered were: what were the priorities for addiction and mental health within the specific regions? What could a Northern Center of Excellence do to help address these priorities? What model would be best suited for Northwestern Ontario? And would people support the development of a Center of Excellence and mental health for Northern Ontario? As you can imagine, with a very wide geographical area, this is a description of where the engagement took place. I think I might have a pointer. So for those on webinar, these were the key areas where you see the little stars, where we had face-to-face meetings. We tried to have one meeting in each of the Northwest LHIN sub-region planning areas. So in Northern, Kenora, Rainy River, the City of Thunder Bay, and the District of Thunder Bay. And then we also wanted to ensure that if folks couldn't come face-to-face, that they would be able to connect through teleconference and video conference. And then this number represents the total number of people engaged in those areas. So we had in total 14 face-to-face engagement sessions, 12 teleconference and video conference engagement sessions, and after all of that was done, one follow-up survey went out to all of the participants in the engagement sessions. In each engagement area, which follow the Northwest LHIN sub-region boundaries, we sought out frontline workers and managers, policymakers and planners, and people with lived experience. In less populous places, all of these people sat around the same table, and in the city of Thunder Bay, there were separate engagement sessions held for each of those groups. What I would like to point out is there were 216 total participants, and 65% of those were from towns and rural areas and First Nation communities outside of the city of Thunder Bay. And 65 participants were affiliated with Indigenous organizations and First Nation communities. And you can see from the pie graph just the different sectors that individuals had identified that they were coming from. This is just a sample of many of the individuals that we heard from throughout the engagement session. So you can see a wide range of individuals who use services, who navigate folks through services, or have touched folks on the periphery of mental health and addiction services in Northwestern Ontario. I'm going to now pass it over to Dr. Mushquash and Dr. Hill to go through the results of those of the engagement sessions. So I think that should catch everybody, so we shouldn't have to move the speaker.
I'll start off with it and tell you a little bit about how we did the district engagement session. We went out to the region and held sessions first in Marathon and Long Lac. Then we went to Kenora and Sulakaut. Those trips were done in November and December a year ago. We went to Port Francis in January, and then we went back to Thunder Bay and held a series of sessions here in February and March. Each of the sessions was distinctive, particularly out in the district, because each district had a somewhat unique set of challenges. Everyone, regardless of where we were talking to them or what they did, emphasized the need for additional local services with emphasis on treatment and aftercare. And at the same time, they underlined the fact that there were a lot of people who required care and specialized services that were not available. Age-appropriate and culturally diverse resources were needed in many cases to provide the type of care that was needed. Okay, Kenora District, as you can see from this word cloud, the main issue was that they had a lot of services that were not available locally. The emphasis was on services not being available for people with dual diagnoses. There was also a lot of concern about people that were at risk, elders and youth as well. And the other thing they talked about was the fact that the care pathways were so complex. A lot of services existed in isolation, and to refer a client from one to another was often a lengthy and challenging process. The other thing was that there was a lack of culturally supportive care for Indigenous clients. This was an ongoing issue as there were significant numbers of people who came into Kenora specifically to access services. Rainy River was unique in that they had a long history of collaboration among service providers, and their priority was building on this to improve access to addiction and mental health services. But like the other areas, they had limited services, particularly in the area of aftercare. The other thing that was unique in Rainy River was that they were starting to see some addiction issues that previously had not been visible. Dysmorphine or crocodile and crystal meth were starting to become real serious issues, particularly among youth. The other thing that they mentioned was there was limited aftercare available locally, particularly a lack of supportive services for people who were homeless or for women who were experiencing violence and domestic abuse. So it just wasn't only treatment that was lacking, but other supportive services. If we look at Thunder Bay District, and by Thunder Bay District, we mean the district east of Thunder Bay, again, they had serious lack of local services. No detox center, no detox beds, which meant that anyone who required detox had to be sent either into Thunder Bay or elsewhere in the province. The other issue that they faced was local aftercare was extremely limited. There were just a handful of service providers doing the aftercare, and there were very complex referral pathways. The other problem, as you can see down there, was not only were there wait times for treatment, that when people were waiting and after they came out of treatment, there were significant food and shelter issues. Lack of safe housing was an ongoing issue, and all of the people we talked to from the small communities said that while they were working on this, it was going to be a challenge. Chris?
Thanks, Marielle. Thanks, Cynthia. And thanks all for being here. The Northern District engagement session was attended by providers from Sioux Lookout, Dryden, and Red Lake areas. And the discussions here centered around the challenge of meeting urgent needs for treatment, limited access to aftercare, long waits for specialized mental health services, lack of supportive housing, which were all things that sort of led to complications in the recovery for folks that were experiencing difficulties in mental health and substance use. There were local needs expressed for integrated mental health and addiction services, and Indigenous specific mental health and detox beds were things that were emphasized in this engagement session. People described complex referral pathways that made it difficult for local providers to follow clients who had been referred elsewhere for treatment. So in those cases, people would, for example, leave their area to go somewhere else for a service, but their local care provider had a difficult time with the communication aspects, which you can imagine is quite important, particularly when that person will be returning home. Staff who relocated to the Northern District from elsewhere in the province spoke of needs for training about different issues in the North. So, building capacity with respect to local knowledge for those who'd moved into the region. And finally, they spoke a lot about cultural sensitivity training as a priority for those who are working with Indigenous clients and Indigenous communities in particular. In the Thunder Bay City District, there were 6 in all sessions, which included managers and frontline workers who serve the city and the region, as well as people with lived experience. Emphasis was on emerging issues in addiction, trauma, complex care for those who have mental health difficulties, few detox beds, difficulty accessing, or in some cases, no after-hours services, increasing demands for addiction care, and the long wait lists that people were experiencing while seeking that care. Relative lack of primary care services, unclear pathways, which was making coordination between different areas in the health system a challenge for those who are providing care to folks. We heard about vulnerable populations, including people with addiction, trauma, brain injury, fetal alcohol spectrum disorder, and other unique challenges that seemed to fall between some of the cracks. And there was an understanding that that these groups in particular were poorly served. There was discussion around the holistic wellness services that recognize a blanket of care, acknowledging Indigenous ways of life as being a serious gap in services. Frontline workers, including police and paramedics, talked about the need for additional training to assist clients with mental health issues, gaps in the needs of youth services, for example, those aged 16 to 18, specific services for those young people, youth in the LGBT S2S community, extra supports needed for First Nations youth who come to the city to attend school, woman-specific community-based treatment in shelters. So, for example, no residential detox for mothers with children, and they also spoke about drug and human trafficking issues, as well as no francophone services available in the city. Marilyn.
What we did at the end of the project was we prepared reports, one for each of the sub-region districts, and we prepared an overall report. We did this so the district could have access to the information they shared with us, and we also summarized participant views on using a Center of Excellence model to see what people thought about that as a way to build local capacity to provide addiction and mental health services. Now, these are just a few of the themes that came out across the region. The first one was that no matter where we went or who we talked to, they all mentioned the limited local addiction and mental health services. The other issue was vulnerable populations. Across the regions, there are significant numbers of people who are not receiving the kind of care they needed. The other thing they talked about was complex needs, mental health and addiction services. A lot of people had coexisting conditions. The need for food and shelter, addressing physical health issues, and when people had to go out of town for care, the whole issue of transportation. People told us it wasn't an individual issue, it was a family issue, and that needed to be addressed. The other thing, there were barriers in the system that some people were reluctant to seek care, and that was another priority, was finding a way around that. The system challenges that people talked about, again, a lot of workforce issues. Care demands were high, so staff was experiencing burnout, high turnover, and of course, when people left, it was difficult to recruit. The other thing was that coordination of care, as has been mentioned, was very challenging. Multiple agencies, and also for First Nations clients, jurisdictional issues as they move between federal and provincial systems of care. People also spoke to us about funding. In some areas, there seemed to be inequitable allocations between communities, and where funding was given on a program-specific basis, there was an issue regarding sustainability. Also a lot of delivery challenges, because if you have to send workers out to other communities, transportation is always costly, both in terms of the actual costs of getting there and the staff time that's involved. When people also talked about providing care, they said that Southern Ontario models of care do not necessarily translate well to the North. For example, procedures for referring clients from one agency to another, very time-consuming, did not seem to do well in the North, where there was maybe only one place to refer people. And at the bottom, the real difficulty of referring people to get the care they needed was an ongoing challenge, regardless of which provider group we were talking to.
After the engagement sessions were over, we sent out a survey to 90 participants who had shared their email addresses with us. We asked them to confirm priority mental health and addiction issues, selecting 3 top priorities from a list As you can see here, the priority was developing local services for clients with complex addiction and mental health needs, and that was endorsed by over half of those who'd responded. 1 in 3 also saw a need to improve capacity to respond to issues specific to youth and Indigenous people. And 1 in 4 identified needs to enhance services through sharing of strategies for dealing with determinants of health and improving coordination of care, sharing best practices, and training of staff.
Throughout the engagement, we asked people to consider whether a Northern Centre of Excellence for Addiction and Mental Health could improve local capacity to address needs and deliver timely and effective care.
People were very enthusiastic about trying to figure out ways to improve situations, and they had many ideas about how a Center of Excellence could help. One of the things they said was if we had a Center of Excellence distributed throughout the northern communities, we could work together to try and develop a northern community of practice. In other words, create opportunities for sharing best practices among providers. The other thing that they thought a Northern Center of Excellence could do would be to create opportunities for collaboration, both at the local level within specific communities, but also across the region. The other thing they talked about was that maybe we could create connections between potential employers and new graduates, so that the issues of recruiting new providers were not so difficult to solve.
Managers and frontline workers wanted local, comprehensive, and Indigenous research. They spoke of the need for data from health, social services, and justice agencies and demographics to assess needs and plan effectively. They talked about how regional databases of services that organizations could update would improve referral systems. They saw the needs for a system navigation tool for providers, clients, and families. And participants also identified needs to work with university and colleges to ensure that graduates were trained to recognize and respond specifically to northern issues. Participants also felt that a Northern Center of Excellence could build local capacity to help meet client needs, could help with funding applications to enhance capacity to deliver care. Both that specific service, as well as assisting with evaluative processes within ongoing services, was seen as something that a Northern Center could do, as well as providing practical supports, including workshops for frontline workers on different areas of priority that they saw in their work. So, for example, self-care, compassion, fatigue, trauma, as well as education for workers about how to provide services across different cultures and different contexts that was culturally safe. Overall, they spoke of the desire for education, training, and supports to build a workforce to deliver specialized mental health and addiction care that was local. The majority of people surveyed said that a Northern Center of Excellence could help. Those who were wanting to see the actual proposal before deciding whether or not they could support it, only 4 people felt that money could be better used augmenting frontline capacity rather than as part of a larger structure.
This nice graphic is the model that most people favored. This was a blended model. It combined face-to-face services, workshops, presentations, community meetings, and events. People thought that kind of contact between providers and people with lived experience built closer relationships and helped people ensure that they knew what was happening on the ground. At the same time, they saw value in virtual interactions, teleconferences, video conferences, webinars, communications through Skype and email. This was convenient, and they also thought that this could bring out some creative solutions. 78% of people who were surveyed favored this blended model. They had lots of opinions about what it should look like, but the preference here was for a distributed hub and spokes model. And there were lots of debates about where the hub should be located and where the spokes should be. The argument was that ensuring that there were sites, in potentially including a hub in smaller communities, this would ensure resource equity. There was also a preference for having a physical center with a resource library. And they also emphasized the need that whatever model was developed should be inclusive of First Nations and other Indigenous groups, respecting their knowledge, customs, and beliefs. The one provision that was made regarding the virtual internet-based communications was people reminded us that internet is costly and unreliable in many smaller communities, or just not available. So they said that the model would have to ensure that print and audio resources were available as well.
So with that survey, one of the key questions was also to gauge the support for the development of a Northern Center of Excellence. And there was an indication that there was strong support for developing a Northern Center of Excellence for addiction and mental health. The next steps will be taken by the Thunder Bay Drug Strategy. We will work in partnership with our current Northern Center of Excellence advisory group, who has supported us throughout the engagement, and look to further engage partners to ensure that future advisory and proposal development is regionally representative. We'll explore the possibilities for obtaining provincial and federal funding for Northern Center of Excellence. We would like to take this opportunity to thank all of those who supported right from the inception of the concept through to the conclusion in 2018. I would like to give a special shout out to Lakehead University and the City of Thunder Bay IT and Communications Department and colleagues for helping to make this webinar and Facebook Live actually possible for us today. We'd like to give a special thanks to our 10-person advisory committee. So thank you to Nancy Black from St. Joseph's Care Group, Dr. Chai Chang from St. Joseph's Care Group, John Dixon from Dalico Anishinaabeg Family Care, Rebecca Johnson, Chair for the Thunder Bay Drug Strategy with the City of Thunder Bay, Amy Yon, previously with Thunder Bay Counseling, now with Lakehead University, Janice Piper, Thunder Bay District Health Unit, Linda Roberts, Thunder Bay District Health Unit, Shannon Robinson, Northwestern Health Unit, Andrew Ross, Sioux Lookout Mino Yowin Health Center, and Dr. Michelle Spadoni with Lakehead University. And an extra special thanks that all of the folks who participated in the engagement session. We are also hopeful that the information that we've shared within this report and the several regional reports will assist rural and northern communities for providing more effective care for people with addiction and mental health challenges. We'd also like to acknowledge and thank the Ministry of Health and Long-Term Care for the funding, without which we would not be able to do this. We wouldn't have been able to do this engagement session. And if you have further questions, you can contact me. My information is there. All of the web versions for the district report, as well as the overall report, will be found at Lakehead U on the CRaNHR website. They are also going to be posted on the Thunder Bay Drug Strategy website. And my understanding is they will go live shortly after this session is done. For those that are in the room, we do have copies of the full report, as well as a one-pager, well, it's actually two-pager, that's a synopsis really of the full report and the specific Thunder Bay City District report. So because folks are here, my plan is for all of the other areas that we will mail out hard copies to those communities, probably to the locations where the engagement sessions were held, and ensure that the communication to folks who participated in the engagement know that those hard copies are being delivered there so you can access them. In the meantime, they are downloadable on CRaNHR's website or the Drug Strategies website. So at this point, we'd like to open it up for some questions. And I'm just going to double check up in the chat here if anybody has questions online.
Can I also acknowledge the work of the CRaNHR staff?
Absolutely.
All right, cool. I just want to thank also Dr. Pam Wakowicz, Dr. Hallie Moeller for their leadership at CRaNHR, as well as CRaNHR staff, many of whom are here today. Rachel, Sam, Siobhan's here, Elaine, Ali, Christy also worked on it. Who else worked on it? Alex worked on it as well, yes. So I just want to acknowledge this, as you can see, it's a huge amount of work, and it takes a lot of people to carry out activities such as this. So we can't do it without our CRaNHR staff.
And the two facilitators, Alice Sabrin and
yes,
Carol Rowland. Thank you. Do we have any questions online? Radio silence online. Any questions from folks in the room? Yes. So for those on the webinar, the question was, has there been anything like this in Northeastern Ontario? I am unaware of an engagement process to understand the needs for a center of excellence in that area.
There are other centers of excellence, but not specifically for this that I'm aware of. Yeah.
And you identified that the next steps would be through drug strategy. Are we looking though for an actual center that's physical, or are we looking at the work that's done through the current pillars? That would be my first question.
So the question for those on the webinar was essentially, what is the process for the next steps? So it will be led through myself as a coordinator for the drug strategy. That being said, the members of the current advisory group that help lead and provide input on this project, both to the chair of the group and to CRaNHR and the researchers, have all agreed that they would like to continue on in that role to pursue the next steps. We will recognize that there are still seats that are not filled to be as regionally representative as we can be. So there will be steps taken to ensure that we have a diversity at that steering committee advisory level to better understand the particular needs. The results from the engagement session indicated that it would need to be a blended model. So we would need to do further engagement on, for example, Dr. Hill did say there was many ideas as to where the hub should be located or where the spokes should be located. So all of that would need to be sorted out. So there would be more engagement on that and to develop a full proposal, a better understanding of what the costs associated with that would be, to then put in a proposal for funding both provincially and federally.
And the follow-up question would be, because the current provincial government is looking at budget, do you anticipate being able to be able to draw some dollars from the province at all?
So the question for those on the webinar was about the current provincial government and budget restraints. Am I correct? Okay. So the current provincial government has indicated an investment over the next, I think, 10 years of $1.9 billion that would be hopefully matched federally to better support addiction, mental health, and housing supports. So hopefully they would see this as an area that would meet some of those needs, particularly when previous provincial governments, previous reports, both nationally and provincially, have indicated that Northern Ontario does have some unique needs and could be supported in this manner to better address substance-related challenges and mental health challenges for Northwestern Ontario.
I did commend the chair of the drug former chair, whatever, no that. But point being is, it's been a good 6 years since we started this. And so we finally did a report. I commend the group that made that happen. And look forward to seeing how this will all be implemented, because when we first started to think about having a center of excellence, it was, yes, it was a question, there was no question about how we should get this. And having this survey and this whole report and indicating where we need to go, let's see where we can go. Congratulations. Let's move forward.
Thank you. Okay, we actually have a question online, so all the folks in the room can see this. You've got Facebook recording that? No, okay, so I'll read it out to Facebook Live. When I was at the last engagement session, there weren't too many frontline service providers directly from the First Nations in our area. Did they receive an invite? I didn't see any community wellness workers, NADAP workers, or family counselors there. Do you want to speak to the amount of invitations that did go out?
The invitations were sent out through organizations to the executive directors with a request that they invite not only their managers, but their frontline staff. We did have a fair number of people who were providing direct services to Indigenous communities at the table. However, there were some cases, for example, people from remote communities where they had to log in using a teleconference or a video conference because unfortunately we didn't have any resources to support them attending face-to-face. So while we didn't report on the actual positions held by people, there were significant numbers of people who did provide frontline services, not only in the towns, but we had people from some of the surrounding First Nations communities.
Any other questions? Yes.
Yeah, just a quick question. Will you be sharing this information with the ESOP?
Absolutely. It will be available, like I said, it'll be available online. If the DSAB would like more of a presentation on that, we would be certainly open to offering that. But through our networks, through the drug strategy networks, the links to all of these reports will go out. Yes. So that was certainly an area that the researchers did do some investigation on existing examples of centers of excellence in various different sectors, but to help shape some of our understanding, so both at the steering committee level, researcher level, and then how they presented that information to the communities at those engagement sessions. I believe it formed the basis of developing the graphics that we did. We did have a couple different graphics to visually depict what a center of excellence could look like and some of the facets that it would be able to offer communities.
Extending on that question there. Keep like them. Okay. With like the band officer. Oh, yeah.
So yeah, so it looks like, thanks Brenda for your question. It looks like I'm familiar with most of the workers and was surprised not to see them there. Like with the band office or health centers in the First Nations informed. Each First Nation in our area has a health center.
Yeah, the invitations went out through the health directors. So all the First Nations in the Northwestern Ontario region received an invitation to participate.
Yeah, so Brenda, well, like we recognize that many would have some resource challenges as well as financial constraints on potentially sending individuals to face-to-face. Dr. Hill did describe that there were also teleconference sessions that were held particularly for individuals who identified that they were interested in participating in the engagement session but couldn't make it to a face-to-face session. So some of them may have participated through that format. I'm sorry, I think I saw a hand over here.
My question sort of is a bit related to the one you asked about looking at other centers of excellence, but my question is more Ontario-based and looking at the mechanisms that are already in place, like Health Quality Ontario, the OHA. There's lots of Children's Mental Health Ontario. There's a Center of Excellence for Mental Health and Children, and how those fit in too. And it kind of sends off Rebecca's question about government may not be very forthcoming in money, new money, for things that don't address direct services. So I just wonder how this can be levered with things that are already in place rather than creating brand new. So I don't know if that was thought. I didn't see it in the report, but I do wonder about how you can sort of attain what you're trying to attain, but not make it look like you're doing new things, getting new money. I don't know if that makes sense, but I just worry about both those questions. I think it's great. It's some great research. It also showed our services need help too.
Mm-hmm.
So I don't know if that's a question or a comment. Good luck. Figure out if it's a question or comment. But I don't know if anyone has a thought on that. I think it's a complicated environment right now. That's fine. And how you can move this forward by integrating with other work that's already occurring and available.
Absolutely. So thank you for the question comment. Certainly that will need to be an area that we further discuss, looking more deeply into some of those areas that you were talking about, Health Quality Ontario, the other centers of excellence, and how do we bridge that work while also ensuring that, you know, the proposal that we put forward meets the needs and the desires of what we saw from the results of this engagement study. That
improves outcomes.
Yeah.
And that's what the people want to see, is that people felt better because this is in place.
Right. Any questions online? Okay. All right. Well, I would just really like to thank everybody for coming out, for taking the time. Please feel free to grab a copy of the report that's there for those that are in the room. All of those that have joined via webinar, I will send the link out to where the resources can be downloaded. Future communication will come out to the individuals who participated in the engagement session on where we will be sending the hard copies of the report to. I would also like to encourage you, if you didn't already, it would be great if you could just check off your name to say that you did come. It's just helpful for us to understand who made it on site, and we'll be able to have a copy of this, of the webinar, who attended on webinar. We will also stop the recording now. I will do this, stop recording.